Over to you, madam.
Yeah, thank you. Good evening, all the delegates. Today we are presenting a very interesting topic on chronic pain and pregnancy from the Society of Post Study of Pain, Pune, in association with Bharati Hospital. To start with, I request Swami Madam, President SSPP, to welcome all the speakers and delegates. Over to you, Swami Madam.
Good evening, all. I think I am audible. I am audible.
Yes, yes, you are audible. Yeah.
Good evening, all. As you know, from last year, we have been conducting regular successful academic meets from our Society of Study of Pain in Pune. I want to thank each and everyone for this enthusiastic participation in this academic meet. On behalf of our Society of Pain Society and Pain Clinic of Department of Anaesthesiology, Bharati Hospital, Pune, I welcome all delegates, speakers, and guest speakers. For today's interesting topic, we have eminent speakers with us, Dr. Girija Wagh Madam from Professor OBGY, Bharati Hospital, Swati Bisay Madam, HOD Physiotherapy, Bharati Hospital, and our own pain physicians, Dr. Uttam and Dr. Keniya. Our guest speaker is Dr. Sukanya Mitra from Government Medical College, Chandigadh. I welcome you all once again for this interesting academic meet.
And pain present a unique clinical challenge for both the chronic pain and obstetrical providers, and the challenge further increases by the fact that there are no clinical guidelines to get, help us. And women are more impacted by chronic pain disorders than men. And usually doctors frequently faced with difficulties of managing chronic pain conditions that were present prior to, during, or after pregnancy usually turn off these patients, to somebody, and the brunt is always taken by an obstetrician. And the pain thresholds in healthy women without chronic pain have been shown to increase throughout pregnancy, peaking just prior to delivery. And it is unclear how these findings may translate to women with chronic pain, as such individuals often have hyperanalgesia, allodynia, and or decreased pain thresholds at baseline. Now, the commonest thing that women would complain to would be back pain. And in the current era of quick testing, the moment they do your pregnancy test, even when they are 4 weeks pregnant, they will start having backache. And this is a frequent ailment that we encounter in pregnancy. And surprisingly enough, we do not have any solution to this ailment, because our own Gita of obstetrics, the Williams obstetrics, says that there is limited research, and therefore we are left to ourselves, and there is no proper training given to, especially us as obstetricians, about the pain. And the explanation that we give to the patient is that it has to be a lifestyle, and maybe it's because of the progesterone-related laxity. Now, typically, if you look at the epidemiology, a history of lower back pain doubles the risk of developing pre-pregnancy-related low back pain. Pregnancy-related pain typically starts between 5th and 7th month. 40% of women who experience pregnancy-related backache continue to suffer 6 months after delivery, and 20% report pain 3 years later. Almost 75% women undergoing chiropractic manipulations report significant pain reduction and clinically significant improvements in disability. So we understand that it is a common occurrence, and nearly 72% of women suffer from it. And typically it would be a lumbar pain, pelvic pain, or a combination of both, with a few studies investigating differences between this type. And hip and foot pain are also common during the perinatal period. Now, the factors which are found associated with low backache are usually age, the race, or presence of low back pain before pregnancy, during menstruation, and during a previous pregnancy. And the factors which are not associated are the ethnicity, that especially the Hispanic ethnicity, use of oral contraceptives, caffeine, tobacco, exercise, pre-pregnancy body weight parity, and history of infertility with hormone therapy are not associated with an increased risk. Now, postural changes can be contributory, and this can be physiological, as we know, but as the pregnancy advances, the posture automatically changes with an exaggerated lumbar lordosis, while it can be acquired because many times out of anxiety, women tend to take an abnormal posture. And where would be the pain? It could be upper backache, there could be a lower backache, or there can also be a pelvic girdle pain. And typically, you would have, it would start from the neck to the sometimes numbness in the extremities, to sciatica, low backache, leg pain, pubic pain. Hyperextension would give rise to heel foot pain, accentuated curvature, and rib pain, difficulty in breathing. All these pains are known to be commonly associated. And there are various, I'm sure the physiotherapist is going to speak about all these in much detail, so I'll not take this slide here. What is very important is sometimes you may not understand this pain properly. It can be because of a herniated or a bulging disc also. Because of the current extreme lethargic lifestyle, many times women have so much weaknesses in their back that they are at risk of developing such kind of a thing, which can cause a sciatica kind of a pain. Therefore, in pregnancy, there can be everything from headaches to thoracic outlet syndrome, muscle pains, intercostal neuralgia, costovertebral pain, coccydynia, very common pain that will be coming up, lower backache, and symphysis pubis dysfunction, and also the round ligament syndrome. Now, this round ligament syndrome is another cause of pain in the later part of pregnancy, where the round ligaments get stretched. And typically, they will say that I am having pain somewhere reflecting to the pubic symphysis. Now, this is something which can be explained to them and guided to them by using proper corsets against, because that can help in protecting the round ligament. Now, quickly coming to pregnancy and chronic pain. Now, usually, this is a big factor because pain management teams and clinics often tell the patients to go to the obstetrician, and they say, now that you are pregnant, we cannot deal with it. And this can be because of lack of evidence-based approach, and therefore women during pregnancy especially would land up receiving suboptimal care. And if you look at the overall prevalence of pregnant women with pre-existing chronic pain disorders, it's unknown. Likewise, the general course of chronic pain conditions during pregnancy has not been studied. Pre-existing pain disorders have a negative impact on pregnancy and are associated with increased, sick leave, insomnia, depressive symptoms during pregnancy. Headaches are one such kind of pain. 16 to 18% of women of reproductive age, but the prevalence during pregnancy is unknown. Course of headache during pregnancy is variable. Migraines largely improve or remit during pregnancy in about 1.3% of women, while postpartum period in 4.5% of women, probably they are distracted now towards the baby. And there is an associated greater risk of preterm deliveries, gestational hypertension, and preeclampsia if women have a tendency of having migraines. Rheumatoid arthritis is an autoimmune disorder, as we understand, and it is known to have an improvised course during pregnancy. However, it does cause a lot of challenges for us as obstetricians because of its autoimmune kind of a pathogenesis. We have various kinds of things associated. Sometimes these women are on very high NSAIDs, and then we have to modify them during pregnancy. The immunological challenges may give rise to consequences of abnormal obstetric outcomes. And therefore, there can be some sort of a sustained fetal tolerance throughout healthy pregnancy, or sometimes there can be a fractured fetal tolerance, which can cause complications throughout pregnancy. So rheumatoid arthritis is one such example of a chronic pain condition, which would be prevalent throughout and would want us to look at. Another challenge is anemia, especially sickle cell disease, because it does cause a lot of vaso-occlusive pain and sickle cell crisis. And many a times still now, we do practice in better settings, screening all women for thalassemia and sickle cell disorder. but many a times this may be missed. So whenever a patient is coming to you with anemia, pain, I think we should look at all these conditions also, and they can be responsible. Likewise, the Ehlers-Danlos syndrome, which is actually a connective tissue disorder, which is heritable and which causes hypermobility of joints and skin. And for us as obstetricians, it would be that thing which we'll look for if the woman is having early preterm birth or, cervical insufficiency, or she lands up in postpartum hemorrhage. Now, these people, because of excessive laxity during pregnancy, can have a lot of pain. So when you look at pain in toto, and if you look at pre-pregnancy, intra-pregnancy, post-pregnancy, all these things mandate a lot of lifestyle change, understanding, empathy, and compassion, and that would help them. Evidence lacks a lot, and therefore I would like to congratulate the organizers of this organization for bringing up this point in a big way, and hope is definitely there for around the corner. And therefore, I look forward to better approach to pain. As we all know, there is an enormous amount of options that a physician can provide today, right down from curing patients, treating patients, or providing with psychic solace or pain relief. So, in fact, the gamut of medical intervention is enormous. And I quote Siddharth Mukherjee while I'm saying this. And living with chronic pain is hard, but dealing with those who don't care or understand is harder. And therefore, friends, we all are doctors. I would really, really want you to look at all your patients empathetically when they come to you with pain, not saying that they are malingering, that is just because you are pregnant, just because you delivered, just because you're taking reproduction medicines or you're menstruating. There may be more to it. And that is where we all should stand. And therefore, look at from their eyes and how difficult they must be finding if we don't pay attention to their pain needs. So with this, I thank you for your kindness. And I would like to say this quote about gratitude, that love and kindness are never wasted. They always make a difference, and they bless the one who receives them, and they bless you, the giver, says Barbara De Angelis. And I think as physicians, we should always be there giving best to our patients. Thank you so much for giving me that time.
Thank you so much, ma'am, for such a wonderful talk and letting us know the obstetrician point of view behind this, handling these pregnant females with pain. So now we'll move ahead. As we are aware that inadequately managed persistent pain can result in anxiety, depression, and these all things can impact on the woman's physical, psychological well-being. And they can have adverse effect on pregnancy. So it is our responsibility as pain physicians to manage this pain, especially for women during pregnancy, so that they should not feel that pain during pregnancy as well as lactation. So our next topic is management of chronic pain in pregnancy. It's my pleasure to invite our guest speaker, Dr. Sukanya Mitra, ma'am. Vivek sir, please. She is a professor of anesthesia and Department of Anesthesia Intensive Care in Government Medical College and Hospital, Chandigarh. She has to. Yeah, it's being shared. Vivek, sir.
Shweta, just a minute. I'll try.
Yeah. Okay.
It's visible, Shweta. You can go ahead.
Madam has total of 106 publications, which include 16 books, book chapters, 40 articles in national journals, and 50 articles in international journals. She has been peer reviewer for index journals like Anaesthesiologica Scandinavica, Journal of Clinical Anesthesia, Indian Journal of Anesthesia, Journal of Pain and Symptom Management. She has received multiple awards and grants for national and international forums, and she is a recipient of Dr. Rukmini Pandit Award in 2001. Also, she has received COPS Award in Practitioners Forum in 2003. Madam, please enlighten us with your take on management of chronic pain in pregnancy. Over to you, ma'am.
Am I audible?
Yes, ma'am.
Okay. So I am sharing my screen, and while I'm doing that, it's wonderful to speak to the pain physicians from Pune, and I thank the organizers for giving me this opportunity to be a part of this meeting. My previous speaker has made my task pretty easy, and I'm going to skip some of the things that she has already mentioned. So, I'm basically going to talk about the management of chronic pain in pregnant patients. So, pain during pregnancy can be due to injury, it can be due to pre-existing painful condition, it could be due to associated with headache, breast pain, low back pain, pelvic and abdominal pain, and of course the lower limb pain, etc. Now, why do we talk about chronic pain and pregnancy? My previous speaker has already mentioned but it does cause a considerable amount of burden, and this leads to anxiety and depression, insomnia, hypertension, poor quality of life, and decreased bonding between the mother and the baby. So what are the, then when we come to the management of chronic pain, so let us look at our practice goals. We should have strategies to include or avoid or minimize use of opioids for pain management, highlight the importance of non-opioid therapies like...
Excuse me, ma'am. Sorry to disturb. Can you please adjust your camera so that we can see your face?
Oh, okay. Is it?
Thank you, ma'am.
Yeah. Chronic pain can, so with this, that chronic pain can be challenging to manage the non-obstetric population, and because they can lead to a plethora of, teratogenic effect, miscarriage, etc. So safety issues need to be judiciously balanced with the efficacy issues, which is really not an easy task. Now, when we talk about the chronic pain patients management, so there are certain barriers. That's why we cannot have the chronic manage this very effectively. So one is first is patient related, that they do not report pain, and they avoid taking analgesics. Now, physician related is very important. There is an inadequate training and guidelines to manage pregnancy. Sorry? Hello?
Yeah, madam, please adjust your camera. You are still not visible. Yeah, please. Yeah, thank you so much.
Yeah. Ma'am, have you shared your screen?
Can you see the screen? Hello?
Not yet, madam.
Not yet.
No.
Not yet.
You have to share your screen, ma'am.
Okay, let me see. Sorry about that. Just a second. I think I did share my screen. Are you able to see now?
No, ma'am.
No, ma'am.
Madam, may I suggest you on your screen, you will see that share screen green icon. Have you clicked that before opening up PPT?
Yeah, I did.
Okay, then it's not visible then. Maybe you have to minimize it and share it again.
Once again, you can try, ma'am. It's just like...
Or Vivek, if you have, you can share, no?
No, ma'am has not sent to. Okay. Ma'am, if you can send me, I can share it.
Yes, it's visible.
Yes, ma'am. It's visible.
It's visible.
You can continue, ma'am. It's visible now.
So, as I've mentioned that we should stress on the like opioid management and physical therapy, and opioid therapy should form the third line of management. And if at all opioids have to be given, they should be appropriately indicated. We should discuss the risk with the patient and use the lowest possible dose that is available. And multimodal analgesia, of course, takes up prevalence in this management. Now, evaluating a patient of chronic pain in pregnancy, same as that of any other chronic pain, except that menstrual history needs to be taken, and history taking is similar. Physical examination is also similar, and but what is important is that one must try to rule out depression and anxiety, and neurological examination for sensory, motor, and tendon reflexes needs to be done. Now, assessment is again also the similar. I'm not repeating them. So let us look what is our management goal in chronic pain in pregnant patients. So we need to monitor the patient for alcohol and substance abuse, collaborate with the patient to set the treatment goals, and develop a management strategy both for labor as well as delivery. Now, multidisciplinary management is always the cornerstone of any chronic pain patient. And obviously, non-pharmacological methods, which are going to be discussed later in details, like CBT, relaxation technique, hypnosis, physical therapy, etc., are to be encouraged in the beginning. And now, with this, I come to the management of specific pain during pregnancy. I'm going to talk about certain painful conditions, and my previous speaker has mentioned some more. So let us see. Chronic pain during pregnancy could be pregnancy related, that is low back pain and pelvic girdle pain, and non-pregnancy related like headache, migraine, rheumatoid arthritis, fibromyalgia, low back pain, etc. Now, low back pain, my previous speaker has already mentioned, more than 70% affected, and they are due to multifactorial, due to hormonal weight gain during pregnancy, and of course, for lumbar lordosis accentuates this. Now, coming to the management, like broadly, it has 4 headings. First is the patient education. We should ask the patient to avoid maladaptive movements. Non-pharmacological methods should be stressed. Pharmacological non-opioids should be stressed. And last but not the least, some patients need intervention, which is going to be discussed in detail in subsequent talk. Now, coming to headache, like we must need to find out what kind of headache it is. Like, is it a migraine, tension type, or both? And one can manage it like either management could be acute or it could be preventive. Now, for preventive management, TCS, magnesium, and botulinum toxins can be useful. For acute management, I've already been mentioning non-pharmacological and certain non-opioid drugs can be used. One word about the triptans. They can usually triptan use in pregnancies not associated with major congenital malformation, but use in second and third trimester can lead to PPH. Now, coming to the next common one, that is rheumatoid arthritis. Again, talking about management, like it has been seen that the use of DMRD and NSAIDs decline, and use of glucocorticoid in these patients are quite increased. However, prednisolone, when used more than 20 milligram per kg per day, can lead to certain developmental problems. Now, the another one is the carpal tunnel syndrome. This is quite prevalent, up to 35% of the patients, and usually supportive management and extreme cases, surgical decompression might be required. Varicose vein is also another common condition causing pain in pregnancy, and this is due to increased blood volume and pressure from gravid uterus. And again, conservative therapy is encouraged. So basically, one should take a cautious approach to prescribing opioids. But what is worth mentioning is that pregnancy should not be a reason to avoid treating acute pain because of concern for opioid abuse or neonatal abstinence syndrome. Finally, when I talk about management or giving an overview of management of chronic pain during pregnancy, I need to see some practical points, and it is important to distinguish between a patient with pain without opioid tolerance who will need increased analgesics. So, patient, on the contrary, a patient who is opioid tolerant or on medication assisted treatment like buprenorphine or methadone will benefit more from regional blocks rather than additional opioid therapy. So then, as we say that, what should be the plan for labor analgesia? Well, use of combined spinal epidural or dural puncture epidural for a parturient with chronic pain is recommended. Now, DPE allows distribution and increased absorption of medication from CSF, and neuraxial adjuncts can be also useful. Now, my previous speaker has already mentioned about the DD of pain during labor, and what is important is that these helps in determination and management. Now, if the pain is above the pelvis, it is due to the pregnancy-related pain, labor pain. Low back pain could be because of back pain, lumbosacral plexus pressure, etc. And lower pelvic pain can be because of either fetal head engagement or pelvic girdle pain, etc. Now, how to consider this? Manage, increase the volume of epidural solution. One may also consider concentration of local anesthetic or opioid and add adjuncts like clonidine or dexmedetomidine. Worth mentioning that dexim causes more sedation as compared to sufentanil. Epinephrine in epidural solution has also been used for troubleshooting. Now, some questions about that comes in a day-to-day practice. When neuraxial analgesia remains insufficient, then what should we do? Now, add inhaled nitrous oxide or Entonox, use remifentanil PCA, and start low-dose dexmedetomidine intravenous infusion. Well, these are available in our country. Now, intraoperative cesarean section discomfort, and patient is very anxious. So what to do? We can keep low-dose propofol infusion, but we should keep the patient audibly conversing. Now then, what to do in this kind of patients who are undergoing cesarean delivery and having some problem? Now, patients who are in chronic pain or having substance use disorder, if the patient continues to complain of insufficient analgesia, well, obstetrician needs to be informed that preferably the uterus should not be exteriorized. Neuraxial opioid dosing may be increased, and maybe clonidine 50 to 100 microgram intrathecal can be given in these patients. So I have already told you that combined spinal epidural needs to be done in these patients. Now, patients with chronic pain and opioid tolerance may require an increase in the dose of neuraxial morphine and epidural catheter and repeated morphine for epidural morphine for post-operative pain management. Now, methadone may also be used for management of post-operative patients in such patients. Now, sometimes these patients, refuse regional, so they undergo general anesthesia. In such cases, bilateral tap block and quadratus lumborum block can be useful. Of course, for ERAS, again, multimodal analgesic options are useful. Now, I have already mentioned about this. Important to distinguish a patient with chronic pain without opioid tolerance who will need more analgesics, and patients who are opioid tolerant and will benefit more from regional blocks. And these two needs to be kept in mind. Now, also splitting the dose of once a day methadone or buprenorphine to twice or thrice a day are useful. Now, this is just a table which shows that chronic pain, non-opioid tolerant, not on medication assisted treatment. So what to do for labor analgesia? Combine spinal epidural with very low dose of intrathecal bupivacaine or fentanyl. And cesarean delivery, one can use combined spinal epidural in higher dose of bupivacaine. And they can be also used epidural catheter for breakthrough pain with adjuncts. Now, chronic pain in patients who are opioid tolerant and on medical assisted treatment, for them, the recommended mode for labor analgesia is dural puncture epidural. This is a new mode that has come here. And combined spinal epidural can also be used for cesarean section. Now, I have come to the end of my lecture. Sorry for overshooting the time, but chronic pain management in pregnant patient is a serious concern, and one needs to judiciously balance the pain control versus the safety issues of both mother and the baby. I thank you all for the attention, and I apologize for overshooting the time. Thank you very much.
Thank you so much, ma'am, for your valuable input. Actually, this topic is very big to adjust in so less time, but thank you so much. And definitely, when we talk about pain management, first line of management is always conservative before going to intervention. So we must know the pharmacology for the conservative management of pain, and that's our next topic. So I would like to invite our next speaker, our very own Dr. Varshali Keniya ma'am. She is a professor, pain palliative care physician in Department of Anaesthesiology, Bharati University and Hospital. She's also secretary of SSPP Pune. She has 20 plus years of experience in field of anesthesia with special interest in regional anesthesia. She has been mentor and course coordinator for chronic pain fellowship in BVDUMC Pune. She has always been instrumental in starting acute pain services at Bharati Hospital. She has been faculty for many ultrasound guided block workshops and conferences, and she has publications, 9 in reputed journal, chapter in a book, Pain and Palliative Care. So over to you, ma'am. Please tell us about pharmacology of chronic pain in pregnancy.
Thank you, Shweta, for your kind words. Let me share my screen. Yeah. Is the screen visible?
Yes, ma'am.
Yes, ma'am. Yes.
Yes, ma'am. I would just like to request all the participants, if they have any questions, they can put it in chat box. So at the end of the session, we can discuss. Thank you, ma'am. Over to you.
Yeah, good evening all. At the outset, let me appreciate the earlier speaker, Wagh madam and Sukanya madam, for their excellent talk and great insights into the prevalence and chronic treatment of the chronic pain conditions in pregnancy. Now moving to pharmacology. Yeah, we all know so far that almost 80 to 85% of patients do take some kind of medications in their pregnancy. And out of that, 50% could be painkillers or analgesics. So they might or might not have pain. The pregnancy itself may cause pain, or the patient may present with exaggeration of pain. Chronic pain may have adverse effects on physical and mental health, and medication during pregnancy poses added risk to the pregnant woman. So physicians and pregnant women are always in a dilemma of stopping the medication or reducing the medication so as to increase the ongoing pain, or should we continue with the same dosages? So they are always in a fighting mood with each other. I mean, whether to stop, decrease, or continue. So it's always a challenging for women as well as the pregnant woman as well as the physician. Second, the discovery and development of all the new drugs, be it analgesic, are always supported by various randomized control studies, but they definitely lack in when it comes to a pregnant lady. So there is always a scarcity of resources and clear-cut guidelines. Added to this, there is altered pharmacokinetics and pharmacodynamics in pregnancy, which adds to the confusion. And one must not forget the pharmacogenomics, which is variations in the nucleotide polymorphism, which in turn can lead to altered metabolism of the drugs. The very good example for this is codeine, which is metabolized by cytochrome. The duplication of this hormone may lead to increased production of its byproduct morphine, which may be detrimental to the neonate or fetus. Also, while considering the pharmacology, we must keep in mind that different organs in their intrauterine growth, they have different susceptibility to teratogenicity. For example, the heart is most sensitive during the first 4 weeks of pregnancy, whereas the external genitalia are most sensitive to the teratogenic effect of any drugs between 8th and 9th months. And the brain and skeleton are sensitive from beginning to the end, and they continue to be more developed in the postnatal period also. So these things are to be kept into mind when one considers the pharmacology of or the treatment part, analgesic treatment of any pregnant woman. So while considering the pharmacology, one must not forget the important aspect of counseling in terms of almost all the pregnant women who are on any kinds of drug, that they might have chances of birth defect to almost 3%, or 15% of they might suffer from miscarriage. So before starting any pharmacology, the pregnant lady and the physician should be clear on this and on the equal terms. As said, the drug effect might have the drug effect on the fetus occurs at 3 stages. Within first 3 to 4 weeks, it's a germinal period where the drug produces either all or none effect. So either the embryo survives the effect of the drug, or it just gets aborted. So it's all or none effect. The second period is the embryonic period. It is the most crucial period, and it is between 4 weeks to almost 12 to 14 weeks, where the most teratogenic effect of all the drugs are precipitate. So we need to remember these two effects very clearly before 31st day or within 4 weeks, and then 4 to 12 weeks. Now, the USA FDA regulations initially had formulated the labeling techniques for pregnancy and lactation into 5 categories. This was implemented in 1994, and it was continued till almost a few years back, till 2014. In this, they had categorized the drugs into 4 categories: category A, B, C, and D, and category X. The category A is where the adequate studies in pregnant women have not shown any adverse effect. So the drugs are classified in this category. The most common example is multivitamin. Category B is where the animal studies have not shown any effects, but there are no adequate studies or clinical trials in pregnant women. Category C belongs to animal studies, where the drugs had adverse effect, but there are no adequate clinical studies in pregnant women. But the drug can be continued if the benefits outweighs the risk. And then the category D, where there are no studies either in animal or human beings, but evidence shows that there is risk to the fetus, but potential benefits outweighs the risk, and where the drug can be used for the pregnant lady. Category X belongs to those where the animal studies as well as the human studies shows fetal abnormalities, and as far as possible, they are contraindicated or are to be avoided. After 2014, the pregnancy and lactation labeling rule came into account, which was implemented in July 2020. Here they have added one more group to the labeling system, female and male reproductive personnel in the childbearing age. So this is the dedicated section labeling for the drugs of for the patients of childbearing age. But it clearly provides detailed information for both patients and healthcare providers about the various effects of the drugs. So now with this, let's consider individual drugs in short. To start with, acetaminophen, the favorite drug of all, crocin. It is said to be most safe drug throughout the pregnancy, from start to end, but not to be taken or continued for more than 4 months, and the dose should not be exceed 4 grams per day, though it has very less chances of developing cryptorchidism in first few weeks of pregnancy. But definitely a safer drug and to be preferred drug throughout the pregnancy. The second one is aspirin or acetylsalicylic acid. What literature mentions that low dose aspirin is safer in first trimester as well as second trimester. But again, the risk of cryptorchidism, which is common to all NSAIDs, should be kept in mind. And towards the end of the third trimester and postnatally, one has to remember that all the NSAIDs, they have the tendency to, because they are COX-2 inhibitors, they have tendency to have an effect on premature closure of ductus arteriosus and then in turn developing pulmonary hypertension of the pneumo. So these two effects are common for NSAIDs, more or less similar to all. So to be kept in mind towards the end of the pregnancy. Apart from this, the aspirin is known to have a clotting abnormalities, and one has to remember that it can cause inhibition of neonatal platelets up to 5 days after delivery. Indomethacin is said to be a short-term insurance drug because it can be given with guarded or safely during the first 2 trimesters. But similarly, towards the end of the trimester, end of the third trimester, you need to be careful because of its the said known effect like pulmonary hypertension and ductal constriction. One thing about indomethacin, I would like to mention that it has a reversible inhibition. So this advantage we can take to stop the indomethacin just 2 weeks prior to the said expected date of delivery. So the effect of indomethacin can be prevented. So if the patient is on indomethacin, it is advisable to start the patient on tocolytics. Coming to ibuprofen, ketorolac, and the other 2 drugs like naproxen and celecoxib, the similar guidelines are advisable to avoid in first and second trimester, and then to keep in mind about the premature closure and persistent pulmonary hypertension in the neonate. While these drugs can cause premature closure of ductus arteriosus, in the postnatal period, they may delay the closure of ductus arteriosus because prostaglandin has a role at both the stages, keeping patency of the ductus arteriosus in the pregnancy and closure of the ductus arteriosus post-pregnancy. So being active, being COX-2 COX inhibitors, these all NSAIDs have effect either prenatally or postnatally. Coming to opioids, morphine, about morphine, there are no reports which can have the teratogenic effects much during the first trimester, but definitely the withdrawal symptoms, if the drug is decreased in dosages or if there are altered pharmacokinetics, then the dosage adjustment need to be done. And in the third trimester, again, to keep in mind the withdrawal signs in the neonate. Fentanyl is also said to be a safer drug in limited dosages and under observation. Regarding tramadol, it is said, there are not much studies about the tramadol, but few of the papers mention that it is a weak teratogenic, and the neonate might have the chances of development of clubfoot are there in patients who are taking tramadol. So again, guarded, we can use tramadol. And towards the end of the pregnancy, in the third trimester, there might be respiratory depression and neonatal abstinence syndrome in the patients who are on the high dosages of tramadol. Codeine if the patient is, especially in the foreign countries, if the patient is on long term of treatment of codeine or high dosages, the chances of cleft palate and neonatal abstinence syndromes are more, along with the respiratory depression in the neonate. And to be kept into mind about the codeine regarding the genetic polymorphism, where the duplication of the cytochrome P enzyme may have increased metabolism of codeine and increased formation of the morphine, which may lead to opioid toxicity. Regarding methadone, it has a favorable risk-benefit ratio if it is used for opioid dependence maintenance program. But then again, the dose adjustment has to be done, and one has to keep into mind about the withdrawal symptoms. For the group of drugs in benzodiazepines, again, the first trimester risk of cleft palate and lip are increased, along with increased chances of spontaneous abortion. But more important than that, one has to remember about the floppy infant syndrome towards the end of the trimester, and with the newborn with low ABGA score, muscular hypotonia, etc. About the tricyclic antidepressants and SSRI, what the literature mentions is if the patients are on TCAs and SSRI, they can continue with the drugs, but with caution and with proper counseling. Always keep in mind about the pulmonary hypertension in the neonate and neonatal abstinence syndrome. What they mention most important is the discontinuing medication to avoid symptoms in the neonate may lead to relapse in the mother. So instead of putting it down or completely stopping the drugs, we can adjust the dose and it can be continued throughout the pregnancy. About the anti-epileptics, it is said that second generation are preferred and monotherapy is preferred rather than starting on 2 drugs. Amongst the carbamazepine and oxcarbamazepine is preferred drug because there is low risk of teratogenicity as compared to other agents, and it can be avoided or prevented with supplement of folic acid along with it. There is limited data on pregabalin and gabapentin. There is no human trials or human data or case studies available much. So if it has to be continued only if the maternal benefit outweighs the fetal risk. All-time favorite drug, steroid, as Madam mentioned, it can be in the lower minimal dosages can be continued throughout the pregnancy, and it has to be kept in mind that preterm birth or congenital malformations could be there. If the patient is on sumatriptans for headache, the literature mentions that there is not any major risk associated in continuation of sumatriptans. But definitely the preeclampsia and preterm birth incidences increases with sumatriptan, which should be kept in mind. Again, beta blockers can be continued in low dosage throughout the pregnancy, but towards the end of the pregnancy, as Sukanya Madam mentioned in her talk also, that one has to keep into mind about the neonatal hypoglycemia, respiratory distress, and feeding problems if the pregnant lady is on beta blockers. But it is overall safe drug. The botulinum toxin is said to be relatively safe in pregnancy. So, in conclusion, I would like to say that it is better to avoid ASA and NSAIDs towards the end of the pregnancy especially, but acetaminophen is an acceptable drug throughout the pregnancy. Opioids, if patient is on opioid, could be continued with because they have associated low risk. Tramadol being weak teratogenic, it is better to avoid. Anti-epileptics only if the benefit exceeds the risk. And triptans can be continued in the pregnancy. So specific and safe medications for pain management in pregnancy and lactation do not exist. We have inadequate data on that. Pain in pregnancy and lactation is not rare condition and must be recognized and carefully treated in a safe and effective way with multimodal approach, and women and their health professionals should make an informed consent. Both the physician and the woman should be at the same platform when they start any analgesics and weigh up the potential risk of treating versus not treating pain during pregnancy and breastfeeding. Yeah, these are my references. Thank you.
Thank you, ma'am, for making this complicated topic simpler for us and summarizing all those drugs can be or cannot be given. So without wasting much time, we'll move ahead. Now we'll move ahead to the intervention part of pain management. I cordially invite our next speaker, Dr. Uttam Sidhaye, sir. Sir is a pain management consultant at Deenanath Hospital and Jupiter Hospital, Pune. He's also honorary consultant at Bharati Vidyapeeth Medical College. He's a director of pain management clinic, Pune. He has been GC member ISSP, past president secretary SSPP Pune, life member of ISSP and ISA. He has received Pain Ambassador Award in Acro Pain 2021. Invited as a faculty in various national international conferences. Extensive work on SI joint pain. He also has publication on cluneal nerve, cause for low back pain, and fibromyalgia in Indian females. Welcome, sir.
Hello.
Yes. Can you elaborate on the topic of interventions in pain,
Yes.
in chronic pain pregnancy? Thank you, sir.
So, should I share my screen?
Yes, sir. You have to
Yes,
share.
sir. Yes, sir.
Just a minute. So can you see the screen? No.
No, sir.
Hello?
Sir, your screen is visible. You can share your PPT, sir.
Yeah. Okay. Can you see?
Sir, not the PPT.
Hello?
We can see the Zoom window, sir.
Yeah, you need to open the.
Stop sharing, okay? No, the problem is the MacBook, it is showing.
Sir, can you send your PPT to
I've sent to my.
technical
If you can
Yeah,
send
yeah,
to
I've
me, I
already
can share it, sir.
No, I've shared it in Gmail with Chobe just a few minutes back.
Okay.
Keynote.
Meanwhile, can I ask a question, Dr. Uttam and Dr. Varshali?
Yes, ma'am.
Yes, madam. Sure.
See, magnesium sulfate used in a low dose has been identified to be a good pain alleviating medicine given in dilution intravenously or maybe whenever you are giving spinal anesthesia or any regional pain medicine. Is that so? It helps in increasing the duration of action also and the depth of pain relief. Is that so with magnesium sulfate?
Yes, madam. Generally, for giving blocks, we are using magnesium as an adjuvant to the local anesthetics for non-pregnant patients routinely, like fentanyl or any other clonidine or dexmedetomidine. But in pregnant patient, we don't have any reports or literature providing that. But magnesium, either IV or as an adjuvant to any of the block, definitely increases the threshold for pain or the duration of the analgesics.
Yeah, because now in obstetrics, we are using magnesium sulfate for various reasons, not only prevention of eclampsia and treatment, but also for tocolysis, and
Yes.
for neuroprotection of the babies. And even now, there are quite a few studies which are saying that even in the HELLP syndrome, it causes a lot of stabilization of tissue destruction. So therefore, I was just wondering whether we can, use it as a pain management medicine, because I think in the beginning, magnesium sulfate always went into disrepute because of its low index of safety.
Hello.
Yes.
Look, can someone tell me how to share this thing on the this MacBook? This thing there.
Sir, actually, it's difficult to share it on MacBook because I had experience that I had to switch it over to laptop. Sharing is sometimes not there in MacBook or notebook.
Uttam sir, can you
Can
mail
we-
me? Let me
Yeah,
also try.
you can mail or
He has
No, I've
already
already
mailed to
The
Rahul
only thing is that
Chaubey.
it's in on the keynote. So I'm not. I don't know whether. So you can carry on with
can
the
we?
physiotherapy.
Yeah, I was about
I
to
will
ask.
shift
Can
to the
we?
PPT and then I will share.
Yes.
Okay, sir. We'll move ahead now. So, can we move ahead with next speaker? So, after a discussion in pregnancy topic, we have come to the other aspects of this webinar. So, very important topic, that role of physiotherapy for chronic pain in pregnancy. It's my pleasure to invite Dr. Swati Dise Madam to deliver the lecture on this important topic.
Hello.
Yes, sir.
Vivek's screen is again frozen.
Yeah. Yes.
Should I share? Is it visible?
Yes.
Yes, go ahead, please.
Swati Madam is a principal of School of Physiotherapy, Bharati, deemed to be University, Pune. She is an academician since 16 years in MUHS. She is also associated with Maharashtra OTPT Council, IIP, IFMR. She has done PhD scholar at Dr. D.Y. Patel College of Physiotherapy, Pune. She's a LIC member, UG/PG examiner for MUHS and in universities. She has 16 publications in national and international journals. She has been guest speaker in webinar on virtual reality. She has received 2 awards for paper presentation at prestigious national and international conferences. Madam, I welcome you for this webinar. Kindly enlighten us with the physiotherapy in chronic pain in pregnancy. Thank you, ma'am. Over to you, ma'am.
Thank you, Dr. Shweta. Am I audible properly?
Yes, ma'am.
Yes. Just 1 second. I will share my screen.
Yes, your screen is visible, ma'am. You can go on
Yes.
full screen mode.
Yes. Is it fine now?
Yes.
Yes. Thank you, ma'am. Thank you. Thank you, Society for Study of Pain Pune. Okay, in association with Bharati Hospital, I would like to say thanks to Dr. Madhuri Lokapure ma'am, Senior Member and Trustee of Society of Pain. I also would like to thank you, Dr. Sarita Swami ma'am, President of SSPP and HOD of Bharati Hospital. Special mention to Dr. Varshali Keniya ma'am, Secretary SSPP and Bharati Hospital and other office bearer. Varshali ma'am is actually coordinating with me since long. Thank you so much. And I really like to say thank you Dr. Girija ma'am and Dr. Sukanya ma'am, who had actually started with the pain management and actually done reduce my job. Okay, just one sec. I will. Is the PPT visible properly?
Yes.
Yes, ma'am. Yes. Okay. Now, role of physiotherapy plays an important role in chronic pain management in pregnancy. Actually, as we heard that the medication have a little bit limitation in pregnancy. Physiotherapy generally concerned about the physical dysfunction indirectly that are limiting to the functions. Pregnancy induced, there are a lot of pathologies. I have just adjusted down a little bit a few of the things which causes pain. First one is joint laxity. Second is mainly pelvic and sacroiliac dysfunction, coccydynia, abdominal weakness, nerve compression, varicose vein, stress incontinence, postural backache. That is one of the major concern. And last one is the breathing alternation. We'll go simultaneously one by one. First, the changes majorly occurs from second trimester to the third trimester. Third trimester have a major postural changes has been already occurred, and after delivery again there is the quite variation in the postnatal stage. In early pregnancy and late pregnancy, we generally deal with the muscle function, right? Mainly there is a changes occur in the there is a increase in weight in breast and uterus, right? And weakness in the abdominal muscles because the baby start growing, and that directly causing the pressure on the nerves, and which causes radiating type of pain. Then pelvic indirectly because of hormonal changes and positional changes, there are the changes in the pelvic ligament and the joints. These are the where first the changes occur in the abdominal as the abdominal muscles start weakening, right? Because and indirectly there is an effect on the spine that which causes increasing lordosis, and for that there is a compensatory kyphotic changes in the thoracic spine, and relatively again indirectly changes tertiary changes in the compensatory tertiary changes in the cervical spine. As there is a weakness in the abdominal muscle and tightness in the anterior thigh muscle, it causes anterior pelvic tilt, and that indirectly causes a hip muscle weakness and posterior back muscle tightness. And these postural changes have a directly or indirectly impact on the whole body, which causes, if we start from the neck, there is a pain in the neck. Indirectly, it causes irritation in the arm, and again there is a CTS, carpal tunnel syndrome. There is a pain in the upper backache, that is shoulder pain. Scapula are majorly discomfortable, and that may give a headache and again tight shoulder and neck muscle. Then there is a because of abdominal muscle weakness, there is a low back pain, leg pain, pelvic pain, symphysis, pubic dysfunction, and pelvic girdle pain. Then again, relative changes occur in the lower extremities also because of overloaded joint, irritated cartilages. Okay, the knees goes in hyperextension, and indirectly it causes knee pain and foot pain. There is also changes in the feet, that is drop arches, foot pain, plantar fasciitis, and risk of increase in shoe size. So first we'll start with the joint ligament laxity. That is majorly a risk factor. So any strenuous exercises has to be avoided. Light, stressful, less stressful activities are recommended to the sedentary females. Okay, like example, swimming, walking, biking. Particularly swimming is the one of the best mode of exercises. And again, if the female is doing any aerobic type of exercises, then non-weight-bearing exercises is more preferable. Pelvic floor muscle has a role in handling the internal organs. As there is an increase in uterus, okay, indirectly it causes pressure on the pelvic floor muscle, and that causes the muscle little bit becomes weak. Then because of hormonal changes, there is a little bit slightly laxity occurs in the sacroiliac joint, and again there is a increase in gap in the pubic symphysis. And these related changes are mainly to accommodate increase in size of the baby. Sacroiliac pain could be individually occur, or it can be associated with pubic symphysis pain that causes mainly tenderness on the palpation, and it may radiate it to the groin and even medial thigh regions. And majorly the pain is in weight bearing, and most of the time if suppose like the females who doesn't have, we have to rule out for PID, that means prolapse intervertebral disc. Most of the time it can be misunderstood, that is SI joint pain can be misunderstood as a PID, but that has to be clearly ruled out from orthopedician. Then mainly the multiple biomechanical mechanisms which are responsible for the SI joint pain and pelvic dysfunctions, mainly increase in weight, change in posture, increase in abdominal and uterine pressure, laxity of spine and pelvic structure, and weakness in the floor and abdominal and hip extensor muscles. Physiotherapy have a major role in reducing the SI joint pain and even reducing the dysfunction. We majorly work on transversus abdominis muscle, that is one thing. Second thing, simultaneously we work for the stabilization, that is core muscle exercises including transverse abdominals, external and internal obliques, hip extensor. These are the major postural muscles which help to give us stabilization during all activities. And sometimes the use of belt or corset is also recommended as a pelvic support. Then again, education related to the posture, and again we do expect, because few of the muscle goes in a tightness and few of the opposite side of the muscle goes in a weakness, stretch weakness. So those muscles which are already in a tightness, we have to give a little bit stretching type of exercises, and those muscles which have a weakness, we'll have to strengthen it. Then heat and ice treatment is recommended. Massage, slight massage is also recommended. Again, high frequency, medium frequency modalities are contraindicated for the spinal region during pregnancy. Then positioning plays an important role while and sideline position. In supine position, the lumbar lordosis is little bit increased. So under knees, the pelvic pillow is recommended. And even in sideline position, because the upper thigh goes in adduction, and that may cause a SI joint pain more. So maintaining the symmetry of the body, the pillows can be kept under the leg, between the leg, to maintain the leg in a straight position. And sometimes we do give a SI stretching exercises, that is mainly for the mobility. And these are the one of the corset which can be recommended. Then coccydynia, that is pain in tailbone, mainly the pillow for sitting is recommended. Then strengthening of pelvis muscle, and again strengthening and stretching of the exercises around the pelvis and SI joint is recommended. And even sometime relaxation with the breathing exercises will be helpful for reducing the pain. role of abdominal plays an important role in anyone's life. Okay, it helps in many body functions like urinating, defecating, coughing, sneezing, breathing, phonation, and even singing. Increase in abdominal pressure facilitate in childbirth, protect the internal organ, and also it helps to maintain the posture, and it indirectly helps to provide a core support. The support to the spine and body during all transition movement are recommended. That is through recruitment of the transfer abdominal muscle and external and internal oblique muscles. Then what are the changes that majorly what I have already explained you? Majorly there is an increase in lumbar lordosis. There is a related hyperkyphosis at the thoracic spine, and that hyperkyphosis indirectly causes protraction of the shoulder and also causes anterior angulation of the cervical region. Then there is a weakness in the hip region, and the female can walk as a changes in the posture that is called as waddling gait pattern can be seen. Exercises from first, second, and even early third trimester. Okay, we can recommend it for a few exercises. Like example, this is a quadruped position with the hip extensor and scapular muscle activation, and including the abdominal muscles are anti-gravity. Against anti-gravity is getting activated. Then bridging exercises and spinal stretching exercises. We do ask the patient to give ergonomic advices related to the posture. During a standing position, even in sitting position and in other position, we do ask them to recruit the transfer abdominal muscle so that the load on the spine will be reduced and little bit the posture is corrected. These are the few different positions where the transverse abdominal muscle is recruited. It is mainly to give pelvic tilting exercises, that is posterior pelvic tilting exercises are recommended in all positions. Then nerve compression. Carpal tunnel syndrome is one of the common pains generally seen, and even in lower extremity, the radiating type of pain is expected due to weight of the uterus, fluid retention, hormonal changes, and circulatory compromise. So first we do give a stretching exercises, then also strengthening exercises to the muscle which are weak. We majorly work for the symmetrical body posture. Okay, some manual techniques, that is MFR, massage, can be given to relax the muscles and reduce the tightness of the muscle. Ergonomic assessment has to be needed because few females can be working and few female have a sedentary lifestyle. Depend on that, the treatment protocol has to be managed. Then modalities like TENS, icing, and hot pack can be given to reduce the tingling type of pain and nerve irritation pains. And sometimes splints can be recommended. Varicose vein as preferable ankle toe movement is recommended. Elevation of the limb with compression and Burgess exercises are advisable. Then trace incontinence is due to pelvic floor muscle weakness, also abdominal muscle weakness. So that's why the intervention is we'll have to give a transverse abdominal muscle strengthening, then external and internal muscle strengthening, then pelvic floor muscle exercises including Kegel exercises, and with abdominals relatively back extensors and hip extensors muscle has to be recruited, means strengthened. Postural backache, that is generally due to stress, weakness, asymmetry, hormonal changes, and weight of the baby. So we do give a Jacobson relaxation technique that helps in relaxation of the whole muscle, all body muscle, right? And that relaxation can be advisable with the breathing exercises. Positioning in all position, like supine position, sideline position, sitting position, standing position. In all position, we give a advice so that the lordosis has to be little bit reduced. Okay, lordosis can be flattened, and load on the abdominals and back extensor can be reduced, and the other postural muscle that can be indirectly get activated in that particular position. So ergonomic advice plays an important role for postural backache. Then in the last trimester of the pregnancy, growing baby pushes the uterus against the diaphragm. The diaphragm is moved up around 4 centimeters. So automatically the lungs get compressed and the ribs are little bit laterally flared up. So intervention is relaxation with the deep exercises and mainly positioning. Okay. And then diaphragmatic breathing, we do give strengthening to the diaphragmatic muscle, and thoracic expansion exercises are recommended. Ergonomic care, that is daily activities has to be made changes. That is one thing. Asymmetrical forces has to be avoided, right? Symmetrical position in all position will be recommended. Then single leg weight bearing, excessive abduction and sitting on very soft surfaces has to be avoided. And generally we do advise them to activate all core muscle in all positions, sitting, standing, and even the lady who is on working. Then post-delivery, there is a chances of pneumonia. Then we do teach them the cuffing and huffing techniques. Then majorly with the breathing exercises. Then post-surgical pain can be reduced by supporting the suture side, and majorly we do work on the abdominal weakness, that is diastasia recta, and will help in reducing the adhesion formation at the incisional site. Diastasia recta is one of the common condition we generally seen in all pregnant ladies. Any separation larger than 2 centimeter is known as significant. So these are the few glimpses of the diastasia recta, and sometimes the diastasia recta can have a more stretch mark, and sometimes that is really an awkward situation for the female also. So that can be reduced when we start the exercises at the first trimester and second trimester. Again, while starting with any exercises, first trimester, second trimester, and third trimester, okay, absolute contraindication and relative contraindication has to be checked out. The intervention for diastasia recta is mainly transfer abdominal muscle exercises, oblique strengthening, right, and crunches, pelvic bridging, and there is a combination of more lower limb exercises for the diastasia recta correction. Then mainly for the scar, that is Caesarean scar, physiotherapy again plays an important role because we do give a scar mobilization. So indirectly, directly we are helping to reduce the adherency of the scar to the underlying structure. The friction massage and kneading can be recommended, okay, and including the lower abdominal muscle strengthening so that the muscle will be mobile in that particular area, and that will help to loosen the scar. And sometime after the delivery, the ultrasound can be used to reduce the adherency of the scar. These are the few exercises, that is pelvic tilting exercises, positioning, that is hip abductor strengthening, then curl-ups, then diagonal curl-ups, then bridging, and then upper extremity exercises, and even planks. Plank are the best exercises which activate the extensor muscles also, and even the flexor muscles also. Then stretching and strengthening exercises include lower abdominals, upper abdominals, hip extensor strengthening, and even sometimes the piriformis stretching is plays a huge role in reducing the pain. Then pelvic floor muscle, that is including wall squat. So these are the different exercises we do recommend or we do prescribe to the patient. With the exercise, ergonomic care is important. That is maintain correct position in all ADLs. Like example, baby feeding. Then again, avoid baby feeding the baby has to be supported on the pillow. Avoid any direct jerky movement from the spine. Try to bend from the knee so that the strain on the spine will be avoided. And again, whenever the lady is carrying or female is carrying the baby, make sure that we just ask her to carry the baby in a symmetrical posture so that indirectly the asymmetry will be avoided. So these are the few physiotherapy advices. So with this, I would like to thank you and thank you for giving me opportunity to present.
Thank you so much, ma'am, for giving us overview on physiotherapy and different exercises. Now, I would like to again invite Dr. Uttam sir for his talk on intervention, pain management in pain in chronic pain in pregnancy. Over to you, sir. Sir, you're muted. So we can see the slides. Sir, please unmute yourself.
The slides are being shared, sir. You can continue.
Sir, please unmute.
Unmute करावं लागेल, sir. Mitra आहे. Yes, sir.
Hello.
You are audible, Uttam. You can go ahead.
Okay, thank you very much. So by God's grace, this is the last thing, and by the sequence, now I am in the last. So good evening, everyone. First of all, I thank.
Don't worry, we are awake.
No, but the intervention should be the last thing in the pregnancy. Though fortunately, the sequence is now appropriate. So thank you, everyone. Thank you, SSPP, and glad to meet Dr. Girija, madam. I started my initial practice with her. My topic, in a sense, it is simple and as well as it's a little complicated also. So when we are talking about the intervention in pregnancy, next slide, please. It's a very difficult task. When patient comes with pain and she is not responding to any conservative management, then there are a lot of things in our mind what to do next, how to give her pain relief. So there are so many hurdles in treatment of this pain management for the lady, pregnant lady. So there are pharmacological challenges. You have covered that thing. Even imaging challenges when we are used to fluoroscopy, and that way we were not used to ultrasound initially. So that was a big challenge. And even when we are thinking about the giving position, because most of the patient comes with the back pain, and most of the time we are trained in the prone position, doing procedures in prone position. So positional challenges are very much when we are dealing with the this pregnant patient. Next. So you all have covered all this thing. What are the reasons of pre-existing pain can exacerbate, like rheumatoid arthritis, even the migraine, even the fibromyalgia can exacerbate in pregnancy. There are non-obstetric pain arising from the pregnancy or pre-existing pain exacerbated by the pregnancy. This is because of the changes in the maternal anatomy as well as physiology and changes in the posture. All you have covered everything in detail. So that is because of the gravity of the uterus, gravid uterus, and as well as the joint laxity and pelvic tilt. So because of that, you get a pain. Even the stretching of the spreading of the symphysis pubis can give rise to pelvic pain. SI joint mobility can cause pelvic pain. Even the pelvic tilt can give the extensor abductor and ankle plantar flexions, increased use of these muscles. Next. So in Swedish study, there are a lot of studies about the back pain in pregnancy. So almost 76% reported back pain during the time of pregnancy. The range varies from 16% to 76%. The good thing for us, fortunately, the vertebral disc pain is 1 in 10,000. So that is sometimes the patient come with this thing herniated disc, and that pain is very excruciating. But the incidence is very low in that thing. So next slide. So the problem in treating with this pregnant patient is that we don't have much data available. There are no randomized control trials whether we should go for the intervention or we should wait for any procedure. So there is no randomized control trial, and there are no guidelines as such to how to treat the pregnant chronic pain in pregnancy. So most commonly used treatment is either physiotherapy, water gymnastic, hydrotherapy, even the acupuncture puncture sometimes helps, pharmacological management, and rarely intervention or surgery in that sense. So what are the common obstetric problem which may need intervention is that nerve entrapment. That is very common. This is because of stretching of the abdominal wall causing the entrapment syndrome. So nerve which are piercing through the rectus abdominis muscle can cause traction and entrapment of this muscle, these nerves, and can cause unilateral pain below the umbilicus. So if you are getting such kind of pain in any pregnant patient, you can give local anesthetic and steroid, because steroid, the gynecologists, obstetricians are also giving steroid for the pregnant patient. So there is no harm in giving local anesthetic and steroid of a single shot in such kind of nerve entrapment. Even the people have seen the iliogastric and genitofemoral or lateral cutaneous nerve entrapment. In those cases, also local anesthetic and steroid under USG guidance can reduce this pain. Carpal tunnel syndrome, there was no evidence available for any intervention for the carpal tunnel syndrome, only the elevation of the limb, because it is because of the fluid retention and fat deposit. So elevation of the limb and splinting, that is the only thing we can do. No rule of intervention in the carpal tunnel syndrome. Coccydynia is one of the major reason for the patient come to you for the chronic pain in pregnancy. So coccydynia can exacerbate during the pregnancy as well as after the delivery. So 60% of the patient responds to local infiltration with local anesthetic and steroid. Even the heat pack and ring cushion may be effective. Headache, tension type headache and migraine is the commonest form which we can see in a pregnant patient. When we are diagnosing the headache as a migraine or tension type headache, please exclude preeclampsia and subarachnoid hemorrhage in these patients. So trigger point injection may be helpful in tension type headache. And migraine, because botulinum toxin you can use sometimes in pregnancy, so you can try that thing if the patient is with a refractory migraine. There are some neuralgic pain, pre-existing trigeminal neuralgia or glossopharyngeal neuralgia may exacerbate. I have come across with one glossopharyngeal neuralgia patient in pregnancy that pain exacerbates. So I did one procedure for her. So USG guided peripheral nerve blocks you can try in this thing if the patient is not responding to simple medication. Prefer investigation in all these things in back pain as well as in neuralgic or trigeminal neuralgia or glossopharyngeal neuralgia is MRI. So to rule out other causes of back pain like herniated disc or any fracture, MRI is the best investigation available. The conservative management is a choice of treatment if there is no weakness. Otherwise, and bed rest is in the supine position with raised feet and flexion of the hip. Physical therapy TENS is have given good results in back pain, reduced physical activity, and I asked females. It is a little scary to tell female to low heel shoes nowadays, but that is a treatment for avoiding the back pain. So intervention if in back pain, if pain is not responding to conservative management, then the intervention can be, you can give a thought of it. The problem faced during the intervention is imaging technique, because we are used for the fluoroscopy and using the ultrasound for the lumbar intervention is not advisable. So that is one problem when we are facing when we are doing intervention in pregnancy. Even the positioning of the patient. If the patient in the first trimester, you can go ahead with the prone position. But if the patient is in second or third trimester, then positioning is also a problem. Epidural steroid, there is no data as such available, or whether we should go or avoid with the epidural steroid, but it can be considered during the second and third trimester. Prone position is possible in first trimester. Lateral position is preferred in second and third trimester. I think Dr. Varshali did one caudal epidural recently in the Bharati for the pregnant patient in the lateral position. So USG is the only imaging available for any intervention in pregnancy, even though radiological exposure for most diagnostic procedure do not involve fetal exposure above 0.05 Gaia. So use of epidural steroid during pregnancy is controversial. No guidelines are established addressing the use of corticosteroids in pregnancy. While using USG, advisable to use Doppler USG imaging, better to confirm the intravascular, though it is not sure whether we are intravascular even if we are using Doppler, but it is advisable to use Doppler whenever you are using USG. So this is a Relton Hall frame which the surgeons have used to do a surgery for the pregnant patient. So this is a Relton Hall frame which in the second or third trimester you can use that thing. And there are some reports about the surgery when the patient is pregnant because of the herniated disc. So next slide. Therefore, few publications available for surgical intervention in case of cauda equina. And there are 2 or 3 papers about the Korean surgeon performing endoscopic surgery for herniated disc during the pregnancy, that is Kim et al. And Hayakawa et al. Data is very limited about the surgical intervention or endoscopic intervention in pregnancy if the patient is coming with the herniated disc. So no such data available for the use of fluoroscopy in pain procedures, but few papers are available about the fluoroscopy in ERCP. So they have done ERCP using the fluoroscopy, but the mean fluoroscopy time was about 14 seconds, range from 1 to 48 seconds, depending upon the time taken for the ERCP, and estimated fetal radiation exposure was 40 mRad. There was correlation between fluoroscopic time and the radiation exposure. So they follow up that those females and 2 women developed third trimester preeclampsia, and labor was induced in both. And 13 out of 15 patients who delivered were contacted, and they confirmed that their child was in good health. So they have, but there is no data available as such use of fluoroscopy in pain management. In my experience, what is my experience about treating pregnant chronic pain patient having pregnancy? I treated one glossopharyngeal nerve block. I did pulse radiofrequency ablation because I thought there is no harm using pulse radiofrequency ablation. I did use a blind technique because I was not comfortable using ultrasound for the glossopharyngeal. The patient was in third trimester. The pregnancy went uneventful, and she delivered a full-term baby without any complication. I didn't, but the department of Bharati pain department, they did caudal epidural for the disc pain, uneventful till now. And I did one trigger point injection for myofascial and tension type headache, which was uneventful. So this was my experience about treating chronic pain in pregnancy. So what is the take home message for everyone is that conservative management is the best thing to do when patient is coming with the chronic pain and she is pregnant. So local anesthetic steroid should not be under fluoroscopy should not be tried. You should not use. You should always use ultrasound if possible, or sometimes you can without ultrasound also. Sometimes if it is safe to use, because I have used a blind technique. But there is no data as such available to use all these things. So rarely surgical intervention with cauda equina and motor weakness. So this is the take-home message for. Thank you very much.
Thank you, sir. Sir, I would like to ask one question in pregnant females. As you said, local anesthesia infiltration with steroid. So what do you prefer? Without steroid also it might have good effect for
as such, even the gynecologists are using, obstetricians are using steroid for the lung maturity. So there is no harm in using that steroid for this patient.
But data is still inadequate.
There is no as such data available and no guidelines available for not using steroid, or whether we should use steroid.
Steroid you prefer, like Exa only or anything?
No, I use Depomedrol in my patient.
Yeah, I would like to share our experience. As you said, Caudal Epidural was given in a pregnant lady. Yeah, a few things about that. We did Caudal Epidural under sonography, but the position was lateral and it was too difficult to visualize the caudal space as compared to what we are used to in prone position in normal patient. Maybe because of the edema, thickened tissues, lateral space, everything was very difficult, what I experienced. This case was done at Jahangir along with Lokapuri madam. It was madam's case, and there we tried under sonography. But it was very difficult, with lot of difficulty. We could visualize the tip of the needle, but not as good as what we used to in prone position and non-pregnant patients. And regarding the drugs, we gave local anesthetics along with steroid, but definitely not particulate steroid. We preferred giving dexamethasone, non-particulate steroid. The patient had extrusion of disc with severe pain. She had been tried on conservative management with medications, but with no relief. So at the last resort, madam decided to go ahead with Caudal Epidural. It was Lokapuri madam's case, and she decided to go ahead with Caudal Epidural, and it did give a good pain relief to the patient.
Yes, actually the feedback is that patient has been absolutely pain-free. And frankly speaking, I'm not too convinced with this USG guidance.
Yeah.
But at the end of the day, I kept telling Varshali, yes, this is loss of resistance. And this is what I would trust. And finally, that's what we did. So, but fortunately, Varshali could also show some kind of fluid presence while I threaded the catheter in. So I guess both of us were happy. But yeah, it was difficult. But the take-home message is that one, I agree with Uttam, because now we have got lot of data with corona patients. I know at least 3 or 4 patients whom I have seen who received very high doses of steroids because of their corona status and who had absolutely normal babies. So I don't think steroids should hold you back. Secondly, you need to give them steroids because you don't want a short-term effect. You want something much longer lasting, and you can't keep doing the procedures in these patients. So I agree that steroids should be used in the doses which we are using. And secondly, try to use intervention over giving NSAIDs, especially in the 3rd trimester. Because not just closure of the PDA, but also the kidney function and everything gets affected for the baby. So much better to do the intervention where it is possible.
May I ask one question, ma'am?
Sure.
Varshali ma'am, Lokapur ma'am. If this case wouldn't have been possible with USG guided caudal, and as she mentioned, patient had intractable pain. So was this patient could have been taken for surgery? Obviously, we can't do fluoroscopic intervention. So
you can do fluoroscopy. You see, I checked with the radiologist. What they say is organogenesis happens. I'm sure Dr. Girija can correct me. It happens in the 1st trimester. So by putting this patient under fluoroscope for 5-6 exposures would not have mattered. But of course, we got away without it. But yes, in these situations, you can use fluoroscopy.
But then in lateral position, it will be again a difficult task. You will have to adjust the fluoroscope in such a way. Yeah.
Can I speak?
Yeah, Sukanya ma'am, any difference in opinion? Yeah.
Just want a point about Dr. Sidhaye when he was speaking. Like, I think that nowadays particulate steroids are not, advised because, and especially this has lot of medical legal implication. So what Madhuri you did is probably the best thing. That is use of dexamethasone along with local anesthetic, and that should be the method of choice if at all given. And to answer the question, like if you can't locate with ultrasound, but like when we do both ultrasound and caudal under fluoroscope, like we do see that definitely fluoroscope is much better. Like, but having said that, like if at all you can't do, you can still do a blind technique as well, because for years on, like, people were doing, and caudal is pretty simple procedure which can be done, and the effect is good in pregnant patients. And one more thing is that dexamethasone, we have used dexamethasone in conjunction with local anesthetic for labor analgesia. And single dose dexamethasone should not be a problem, although like, huge heavy dose is not warranted in this kind of patients. Thank you.
Any questions?
Dr. Shweta, can you check in the chat box?
There are no questions on chat box. Actually, I checked the YouTube link also.
Okay.
So, shall we move ahead? Okay.
Yeah.
Thank you. It was a very brainstorming session, right from the prevalence to the interventions in pregnancy. So I'm sure that we all have gained some knowledge and will go ahead in our practice with this. So now in the last, I would like to hand over this session to Dr. Joyshankar Jana sir for the vote of thanks. I thank all the speakers for joining us in this session, and would like to have you later for more seminars like this. Thank you all. Good night. Over to you, Jana sir.
Dr. Jana, unmute yourself.
Yeah, unmuted myself. Yeah, on behalf of the Society of Study of Pain, Pune City, I give the vote of thanks on behalf of our president, Dr. Sarita Swami, and the complete executive committee of SSPP. First, I'll give a vote of thanks to all our guest speakers, Dr. Girija Wagh, my old dear friend, Dr. Sukanya. Bharati, thank you so much for coming and sharing your thoughts with you. And Dr. Swati Pise Madam, who gave a fantastic lecture, a very different insight to the physiotherapy and the physiotherapy during pain and pregnancy. And to our local speakers, of course, starting with Dr. Uttam, Dr. Varshali, and who else is there? I'm sure everybody. And also, huh? Have I missed anybody? No.
No.
So I also thank our anchor, Dr. Shweta, and Dr. Vivek, who has been instrumental in organizing and collecting all the data and all, and of course Varsha Kurade, over enthusiastic and fantastic as ever. And overall, under the guidance of Dr. Madhuri Lokapur, we had a very fantastic webinar this evening. I hope everybody has enjoyed. Of course, Uttam has finally given the bottom line of interventions in pain management. And let's call it a day. It's already more than 9:45, 9:50. So thank you all for joining us. We'll wait till we meet in person again Of course, we'll be meeting when we meet in Bhubaneswar in person. Till then, cheers to all and long live SSPP. Thank you.
Thank you.
Good night, everybody. Bye.
Bye. Thank you.
Bye, ma'am.
Wagh, madam.
Thank you.
Sukanya, madam.
Hey,
Thank you.
Girija,
Thank you.
झोपी नका.
Thank you.
अरे नाही गाडी चालवते.
अच्छा.